So it's nice to meet you all. So I'm a vascular surgeon, office just across the street, about a mile away. Jeannie Cross is my nurse practitioner. Sure. So Jeannie Cross is my nurse practitioner. She's away at a family emergency, otherwise she would have loved to be here as well. We actually did come here about a year and a half ago, and we did a screening fair here, I remember. Hopefully we saw some of you, but I remember we had a bunch of tables lined up and a bunch of ultrasound technologists here, and we sort of screened people for a lot of the diseases that we're going to be mentioning here, and hopefully we'll set that up again down the road. But so what I would like to ask is that if you have questions, I'd love to get them as we go. So just raise your hand if you see something on the slide that you want more clarification on or something about you want to learn more about. Raise your hand, I'll call on you right away. So our goal here is to talk about peripheral artery disease. Okay, so there's a couple disclosures. And so our objectives today are threefold. First, we're going to understand the risk factors for the development of peripheral artery disease, determine the range of presentations for peripheral artery disease, and understand the associated risk of leg amputation, which is our goal of prevention after this, what I'm trying to teach all of you to try to prevent. And then understand the advances in, as we look to understand the advances in, okay, the treatment options for significant peripheral arterial disease, looking to advance the treatment options. So PAD, peripheral artery disease, is very much a disease spectrum. Patients can be asymptomatic. You could have PAD and not know about it. Or you could develop symptoms which range from claudication, which we'll get into, which is pain that occurs with activity in your legs, or what's called chronic limb-threatening ischemia, termed CLTI, which includes pain occurring all the time, rest pain, or if you develop ulcers or tissue loss, wounds in your feet that are not healing. These are all manifestations of PAD. So overall, the vascular disease population is very much on the rise. Multiple factors that contribute to PAD have been increasing in our population, including obesity, high blood pressure, diabetes. Aging population also exacerbates these trends. So if you look at these charts, the axis on the bottom is all just advancing years. So the prevalence of obesity, diabetes, people with controlled blood pressure medication, and then overall age, these four factors have very much led to a increase in the prevalence of PAD in our society. So is PAD common? So yes, this is actually a study that's almost 30 years old, 1993. At the time, there were 10 million people in the US that had PAD. Half of them were asymptomatic. They didn't know. The other half had symptoms, whether it was pain at rest, pain with walking, or ulcers. The concerning part here is this portion were untreated, meaning they had symptoms and they either never made it to a physician or were never properly diagnosed with their condition. These are the ones that we need to help identify, either by advocating for yourselves or my job to educate PCPs, other clinicians to help refer them to the correct location. So, yes, please.
I would like to ask you, are you speaking only about the back of the leg, or are you also speaking front, like in the shin part?
So it's more commonly in the back part, in the calf, but it can affect other muscles in the leg. So you can have buttock claudication, so pain in your back of your buttocks, or even in your thigh. The most common location is in the calf, but certainly it depends on where the blockages are, affects different muscle groups, but we'll get into it. So who has PAD? So similar, this is a study that's about 20, 30 years old. And at the time, about 1/8 to 1/4 of the population, so 12 to 25%, had PAD. If you notice, this chart, when it was done, ended at age 74. The average life expectancy is well past. We need a new chart. So I added another bar. And so we really don't know, but I can tell you it's more than 8% prevalence at that. So if you saw the flyer, it was about 1 in 5 have PAD. Whether you have symptoms or not matters in terms of whether you need to have an intervention done, but it's important to at least identify its presence. So currently, the estimate is that PAD affects 8 to 12. 8 to 12 million Americans. I told you it was about 10, about 30 years ago. But what's important here is that you all hear about heart attack, stroke. PAD is very much a manifestation that it's very similar to those other disease processes. The reason that someone would have a heart attack is because cholesterol has led to a blockage in the blood vessels to the heart. These are blockages in blood vessels going down to your legs. It's very much the same process. How many people are taking aspirin a day or on a statin medication? It's the same treatment, and we'll get into that because it's the same disease process. But overall, if you took patients with heart disease, congestive heart disease, PAD or stroke, the mortality is actually higher for patients with PAD compared to stroke. It's definitely a significant issue. So these are the risk factors. This is what leads to people to develop PAD. So this is something called an odds ratio. It's a statistical method. So it says if you are male, you are 2 times more likely to have PAD than a female. Similar, if you're, for every age, increase 10 years, you are 2 to 3 times more likely. But if you don't need to, I don't want you to go and learn and memorize all these, but I would say the most important things are the ones that are furthest over to the right, which are diabetes and smoking. Those are the 2 biggest risk factors for development of PAD. Now, I mentioned that this is a disease in evolution. So patients will present in different symptoms or be asymptomatic. So if you develop symptoms, you typically start with claudication, which is this gentleman here that's holding the back of his calf. That's sort of the classic picture. But these will progress to pain all the time, meaning someone might say, I have a tough time sleeping at night because my foot hurts so much. So they end up sleeping in a recliner, or they'll sleep with the foot off the bed, and I'll explain why that occurs. And then the things we're trying to prevent are ulcers or gangrene, black toes, and then ultimately gangrene and losing your legs. So everything after claudication, the little animation didn't show up, is that CLTI, chronic limb-threatening ischemia. So we're going to start with the most benign, which is claudication. So pain in your legs when you walk. So it derived from the Roman Emperor Claudius. So he used to walk for a short distance, then he'd stop and stand before he'd walk in. So that's where they gave the terminology of someone who claudicates. It's overall relatively safe, meaning it can be very inconvenient to your lifestyle, but your risk of an amputation, meaning your risk of losing your leg, is exceptionally small. Whereas if you progress to the CLTI, that risk is much higher. So to touch back on what is claudication type pain, this is, I tried to make a little chart of what is claudication versus pseudoclaudication. We certainly have patients come and see us for leg pain. They may or may not have PAD. If you have these symptoms, it tends to suggest that it's PAD is the underlying cause. Patients will usually say that their legs cramp or they have aching. It can involve the buttocks, the thigh, the calf, or even the foot. It will be related to exercise. That's sort of pathognomonic. So if you walk and you experience the symptoms, then you stop and the pain goes away, that's the most characteristic sign. And I'd expect your symptoms to occur even faster if you're walking uphill because you need to exert more energy. Think of it as that your muscles are exercising. They need oxygen to recover from the exercise, but the oxygen isn't getting there fast enough. So you need to stop, let the blood get there, washes away the pain, the lactic acid washes away, pain subsides, and you can walk, again, another similar distance. So it should not be any better with standing. You actually should feel better with standing because now gravity is helping to bring blood down to your feet. And usually symptoms will resolve within 5 minutes. Any questions so far? Okay. So CLTI, chronic limb-threatening ischemia, which is what we're trying to avoid. The first step is rest pain. So pain that's present whether you're walking at night. Pain that occurs at night, particularly if you're sleeping horizontally in a bed. You've lost the benefit of gravity. If I checked your blood pressure in your arms right now and your ankles when you're standing, you will have a higher pressure in your ankles because of gravity. But when you suddenly turn horizontal in the bed, you've lost that gravitational pull down to your feet. So if you're teetering on PAD and whether you have enough blood supply or not, going horizontal can make you develop foot symptoms. And then that's why people will come and say, I sleep, but I have to sleep on the right side of my bed so I keep my foot down. And that's a classic sign. Then, of course, non-healing wounds and gangrene. What's so important is that if you fall into the CLTI range, your risk of amputation is very high. Of those, 40% of patients will have lost their leg within 6 months. 40% will still have their leg. 20% will have died. The reason for people say, why are patients dying from leg issues? Well, it's a marker. I said it's the same disease process as what causes heart attacks or strokes. It's all cholesterol deposition. So identifying someone with PAD earlier, the treatment includes a lot of the same medications your cardiologist would put you on. I'm not just preventing your legs from progressing. I'm trying to prevent your coronaries, your heart blood vessels from developing any worsening disease. It's the same process. We'll get into this again further on. So why is it important? How can we help identify it? So there's really no detail too small. PAD is a systemic disease, so an exam for your primary care provider is very important as well. So things that we look for, if you find that your lower extremities are cold, you sort of have diminished hair growth on the lower part of your leg, by your ankle, your feet, poor nail growth, dry, scaly skin, then this picture I put on is what's called dependent rubor, elevation valve, so dependent redness. So I mentioned that when you're standing up, you have a higher blood pressure in your ankles. If you have CLTI, or poor blood flow, the blood vessels in your feet are very dilated. They're starving for oxygen and starving for blood. So when your leg is down, those blood vessels fill with blood and gives your skin a rubrous, or red appearance. So saw a patient this morning, similar. So if I took him and I elevated his legs up, that blood will wash away. And the blood, now your skin turns white, pallor. And so classically, we'll go to a physician and say, oh, I have cellulitis. I have redness or an infection in my skin. You get put on antibiotics and it doesn't change anything. Your leg is still red when it's down. If you notice that the color change is very much dependent upon your positioning, then you got to be concerned about PAD being the underlying reason. Things we discussed, tissue ulcers, gangrene, which are sort of more down the road issues, but things we're trying to avoid. So is there a test? How can you check? And yes, it's actually very easy. These are all ultrasound tests that can be done in the office, done in the hospital. So we're going to get into what they are. ABI, I'm going to teach you how it is, not that you need to know how to do it, but it's called an ankle brachial index. A Doppler is that machine that you sometimes will hear a physician use to sort of listen to your feet. Same thing they'll use to check a baby's heart rate in a pregnant woman. A duplex is ultrasound technologists scanning your leg or scanning your arm, same way they do for any other test, or they'd scan for your carotid arteries in your neck. Or a treadmill study. If someone's indeterminate, sometimes we'll have them walk on a treadmill. We'll measure the blood flow when they're just laying there, have them walk 5 minutes until the symptoms arise, and then quickly recheck the blood pressure again. And that helps us distinguish the claudication versus pseudo or fake claudication. Okay. So this is how you measure an ankle brachial index. None of you need to do this. This is stuff that it's my job to teach your primary care providers how to do it. But so basically the way it's done is they'll measure the blood pressure in your arms, just like they do when you get every checkup. They'll measure on both arms, and you take your higher number. 120 on the right, say it's 120 over 80 on this, 140 over 90 on this, they'll take the higher number. Then they'll do the same thing at your ankles, and they'll take the higher number on each side. And you get a ratio. How much blood flow is getting down to your foot compared to your arms. If your number is less than 0.9, so that's like 90% of the blood flow, then that's a diagnosis of PAD. So 0.9 is the number we're looking to keep your number above. So ordinarily, your blood flow down to your feet is 90 to 120% the blood flow that you're getting into your arms. And I explained why it should be higher because of gravity. Go a little bit higher. So these are the numbers that your PCP might get from a test that they order at the hospital or through me. Well, they'll say this is normal, 0.9 to 1.2. I just say consider it a percentage, 90% to 120. And then typically, your degree of symptoms, whether it's pain with walking, claudication, pain at rest, or ulcers, is usually correlated with how bad the ABI is. So 0.7 to 0.9 might give you pain with walking, 0.4 to 0.7 give you pain all the time, and less than 0.4 lead to ulcers and tissue loss. That very much raises a red flag for your PCP, say this someone's at high risk for a leg amputation. Okay. So this is another test. It's a more complicated way, but I wanted to give you a picture of how we do this test. So this is all done in the office or in the hospital, the heart station. Harrington does it. And so you'd go and you'd get these blood pressure cuffs on your legs, and then the technologist will calculate this blood flow compared to your arm. So these are all just a bunch of fancy ways to basically quantify, this goes back, these numbers. Okay. Non-invasive, simple, no needles, nothing. A simpler way, if you're diabetic and you get a test done, if you get this test, sometimes it can be artificially high. So they have specially designed toe cuffs, little tiny blood pressure cuffs that go on the toe. They're really small and cute. They basically, for us, it's something that gives you a more accurate measurement than someone with diabetes. And that's something that we'll explain to your PCP, but gives me an alternate way to measure it without needing to do any sort of invasive test. So what I'm trying to explain is that detection is the important goal here. Unfortunately, in the US, there's a lot of patients that never get offered a procedure before losing their leg. So this was a study done in 2012, so 12 years ago now, where they took all the patients who had an amputation in the United States. It was about 20,000 people. And how many of them had an angiogram? An angiogram is a procedure that I do to look at the blood flow and hopefully fix the blood flow down to your leg with a stent or a balloon or even plan for surgery. 54%, so half the people in the US, didn't even have that procedure, meaning they either were not diagnosed with PAD or they were diagnosed too late. We need to shift more into the category on the right where we identify patients early. And I think a lot of that is really based on social disparities and where you live, and you're thankfully in Massachusetts, there's a lot of healthcare facilities near you. Not as readily available in other parts of the country, but it really is a shame because unfortunately we do see people that come to the ER that have been missed or were never sort of identified before, and it happens here, and that's our goal to prevent. Any questions so far? We're going to shift a little bit about what do we do once we sort of identify diagnosis. Okay, I feel like you guys all open up your own vascular clinics now. So yes?
Is this covered by insurance, the diagnostic?
It is. Yep. So as long as you have symptoms of leg pain or have a history of some of those risk factors I discussed, the ABI is a simple test. It's about $100 to Medicare or whatever. And so, but yes, it is covered. And Medicare would much rather pay for that than the cost of an amputation, hospital stay, et cetera. So what do we get once we find, what do we do once we find someone with PAD? Right? So I find someone has an ABI of 0.7 and they have pain at rest, they have a tough time sleeping. My job now, would take you, handle the referral from your primary care doctor and say, now we need to identify how do we fix it. And it's my job to identify where are the blockages. I know the blockages are somewhere. Somewhere between your heart and your ankle has led to a just level of 0.7. So there are multiple choices you can get, and that testing choice depends on the provider. You can get duplex, which is an ultrasound. Yeah, please.
Do you deal with carotid?
Yep, we do, absolutely. Probably the more common than this even. It's the most common vascular surgery, I'd say, is carotids. But yeah, yeah. So the same. We do all the same. I'll ask you, the ultrasound that you get an ultrasound periodically for your carotids?
I do.
Okay.
I get examined once a year.
Mm-hmm.
And it seems like, at least fortunately for me, it's not going up. One's a little higher than the other.
Okay.
But it's not going higher than the year previous.
Perfect.
So that's a good thing.
Is it a challenging test for you to get done?
No.
Yeah.
I mean, they do your neck.
They just scan your neck just like they're looking for something.
Exactly.
Yeah, so that's the same test that we do in the legs, essentially. So it's non-invasive. There's no radiation. There's no contrast dye. So if you have kidney issues, sometimes we worry about contrast dye. Maybe your doctors have suggested that to you to be a little mindful. But it's the same test. And that test, do you do it in the hospital or in the office?
I'm with UMass.
Yeah, they do it in the office.
Not really. I go in Charlton.
Yeah,
You have a,
in the yes. So it's similar in the office. It's in an ambulatory setting. Like you don't have to go be admitted into the hospital to do it. But yeah, so just the same. We do them in the office, just the same. The office, a mile down the road. The hospital does it, Harrington does them just the same. It's easy. It's meant to be a screening test or for a monitoring test.
Right.
Absolutely. So that's the first step. It's certainly the cheapest way, and it's the least invasive. The next test, these are CAT scans, CTA, CT angiogram. Once something says angiogram, that means it involves dye of some type. So dye now involves an IV, an injection of a chemical, which has inherently some risk. So if you have kidney disease, more if you have significant kidney disease, that dye can increase your risk of needing dialysis. So before you have any of these other tests, you ordinarily will have a blood test done to make sure that your kidneys are functioning appropriately so that you can get exposed to it. But it just says now you've switched to a more of an invasive test, more cost. Most of them involve radiation. MRA is like an MRI, so there's no radiation with that, but similar if you've been in an MRI, loud, noisy, takes a long time, but those are all choices. And those choices are based on, I would have to make the decision about which one of these is most appropriate for you. So an angiogram, which is the last one, is a catheter procedure. I'm going to get into that. So there's advantages to that one compared to the others, but sometimes you'll need others in the meantime. So this first one was a CAT scan. This is an MRA. They'll look a little bit different. And then this is an angiogram. So an angiogram is where a physician would go and put a needle directly into the artery. So if you notice, and some of you maybe sitting in the back have a tough time, but it looks like there's a little pigtail, a little hook inside here. So if you follow that going down, that's going down to the right leg. So the physician inserted that catheter through the groin artery, through the femoral artery in the groin, and positioned it up here. Then they injected dye to see where are the blockages. So this patient may have come in because they had pain in their buttocks on the left side. So the advantage here is that the physician can now look and say, are there any blockages to the left side? So I'm looking down to the blood flow to the left, and I see a nail ring right here. So the black is all the dye that gets injected. And so now here, if you notice, this right side looks pretty clean and smooth, but on the left, there's a nail ring right here, just like a little string that goes through. Another spot right here. So the advantage of an angiogram is that while they're doing this to identify where the issue is, they could put a stent into that artery at the exact same time. So while it's diagnostic to help figure out what is the diagnosis, it's potentially therapeutic, meaning when the procedure is done, the blood flow should be improved and you'd feel immediate relief. So we do these procedures in the office. So you'd have the procedure done. I sort of give the analogy of like a dentist office. You show up, you say, oh, you need a cavity, come back, you need a cavity filled, come in next week. You come to the office, you have the stent put in, you go home about half an hour to an hour later, and your symptoms have improved. And then we sort of monitor you with ultrasounds or CAT scans as needed. So other advantage of this, if you've noticed, is that there are other blockages here. These are the blood vessels that go to the kidneys. If anyone I accidentally touched the screen. Maybe here. There's a little narrowing right here in that blood vessel going to the right kidney. So that's called a renal artery stenosis. Sometimes if you have less blood flow going to your kidneys release hormones to raise your blood pressure up. So I always give the analogy that your kidneys are pretty selfish. They want to have a lot of blood to clear out your toxins from your body. If they're not getting enough blood, they will release hormones to raise your blood pressure so that they get enough blood. So sometimes a kidney physician, a nephrologist, may send a patient and say, this patient's blood pressure is really high and we can't get it controlled despite multiple medications. And then I would identify this with an ultrasound that I would do in the office first, then do this with a plan to put a stent into that artery. And then that allows them to hopefully reduce the number of medications or reduce the dosages. But it's the same process. It's still atherosclerosis, cholesterol buildup, whether it's in the leg blood vessels or the kidney blood vessels or the carotid arteries to the neck. It's all the same thing. Okay. So the treatment options have varied considerably. So I mentioned this is the severity of symptoms: claudication, rest pain, gangrene. I'd always say there's 3 steps to treatment. Medical therapy. Every patient, claudication, rest pain, gangrene, should be on optimal medical therapy. I'm going to get into that. minimally invasive treatment, which is stents, balloons, techniques like that, or surgery, where literally general anesthesia, breathing tube in to reconstruct the blood vessels in different ways. We do all of that. But all patients should be screened for all of these options for treatment. So what is medical management? This is going to match what your cardiologist or your PCP may have already put you on some of these medications. Lifestyle modification. I'll start on that. So exercise. Exercise is very important. So if you can, so I have patients come in and say, I have pain when I walk. I can only go 100 feet. And then I have to stop because it hurts so bad in my right calf. Then I stop for a couple minutes and I can walk another 100 feet. That's fine. And I'd like you to continue to walk. And I'd like you to try to walk through the pain a little bit. Walk 150 feet, 200 feet. You're not causing any damage. What you're really doing is you're promoting two things. You're really promoting your muscles to tolerate, just like an athlete, a lower level of oxygen. And you're increasing the sort of collaterals, the side roads. Think of it as the highway down to your foot is blocked, but there's detours getting down there. You're promoting enlargement of those detours to provide the blood flow down. Smoking cessation, and it's very hard, and 90% of my patients are smokers or smoked at one point in time. But if you're still smoking and you have claudication, I will counsel you extensively that this is where you're going if you were to keep smoking. Your risk of progressing to CLTI and limb amputation is very high. Diet control, heart healthy diet, just as you would with a cardiology recommended heart healthy diet. Blood pressure control, diabetes management. I'd ask you what your hemoglobin A1C is, which is sort of your 3-month marker of what your blood sugars are. And then cholesterol, so statin management. So the medications we typically would recommend are antiplatelet, which is aspirin, baby aspirin, 81 milligrams. You may have, in the last couple of years, been a lot more talk about whether patients should be on aspirin or not. So I would argue that the studies that were done said there was no benefit for aspirin were not patients with PAD. If you have PAD, you should be on an aspirin. So if you're on and you're thinking of stopping it, I'd ask you to talk to your PCP, your cardiologist, me, to decide whether that should be discontinued. Statins, so atorvastatin, this is Lipitor, simvastatin, rosuvastatin, all those to reduce your cholesterol levels. And these two medications are not just for PAD, for your legs. You are likely reducing your risk of having a coronary event, a heart attack down the road. I didn't put this in my slide, but there was a study in the 80s. They can't do this study anymore, but the Cleveland Clinic took 2,000, I think it was 1,600 patients that all had PAD. And every single one of them had a coronary catheterization, meaning a heart catheterization, where they sort of go through your wrist to inject the dye to your heart, whether they had symptoms or not. And 25% had heart blockages. They won't do that study now because they would never be allowed to sort of subject patients to that risk of the procedure. But a fourth of patients with PAD have CAD, coronary artery disease. So that's why I put you on these two medications. I'm not just helping you for your legs, I'm helping you for your heart. And then rivaroxaban is Xarelto. You might have seen commercials for it, like Eliquis, Xarelto, Coumadin. Anyone heard of those names? So a lot of those are given for AFib, atrial fibrillation, which is sort of a condition where your heart defibrillates. Instead of pumping, it sort of kind of fibrillates a little bit. So there's a newer study in the last 2 to 3 years, that has shown benefit in a low dose rivaroxaban, low dose Xarelto for patients with PAD. So I'd say those commercials say the patients will go on 20 milligrams of Xarelto a day. This is about 5 milligrams. It's 2.5 twice a day. It's very much a low dose. And that's a new study, 2021, 2022. So more patients were switching over to a lower version of that. So smoking cessation is the most important risk factor to determine the outcomes of patients with claudication. If you stop smoking when you have claudication, I'd tell you that you're very unlikely to progress to CLTI. So claudicants that smoke are more common to progress. If you stop, you're likely to remain a claudicant or potentially become asymptomatic. I understand this is very much easier said than done. There are plenty of resources. Massachusetts has a sponsored quit line, QuitWorks hotline, that they would contact you and offer you lozenges, patches, medication to assist with that. That's through insurance. Exercise therapy, I mentioned how important it is to exercise through the pain. There is a Medicare-sponsored supervised exercise program where they recommend walking 30 minutes a day, 5 days a week. There's payment for that, meaning your insurance and Medicare would pay for that. It doesn't pay very much, but Harrington does have a cardiac rehab unit where they'll do this for you. Well, they'll walk you 30 minutes a day on a treadmill. Understanding you could do this at home with supplies, but your walking distance improves. What this study showed was patients who started with claudication, if they exercised, so the white, versus the non-exercisers, were able to walk almost double the distance that they could accomplish before. So that's why I will tell you to walk. So CLTI, this is that pie chart I showed you earlier. It's a dire natural history. 40% of patients have lost their limb, 20% have died, and only 40% are alive with both legs after 6 months. So ultimately, your risk of limb salvage is based on what your symptoms presented are. You have rest pain, ulcers, et cetera. And your ABI, that number I gave you, very much correlates to your risk of an amputation. So my job is to save your legs, and the goal here is not just for, let's say, oh, functionally, how do I get around? But your autonomy, your independence is very much affected when you become an amputation. You got to think about things. How many stairs to get into your house? Is the bedroom upstairs, first floor, second floor? How are you going to get into the bathtub, et cetera? So all these are questions that I have to answer, and unfortunately, patients do progress. But these are all things that will factor in. Of course, patients with an amputation have a much higher rate of mortality, meaning once you've lost your leg, your risk of overall mortality is higher. Some will say, well, maybe you have a higher risk of heart attack. Yeah, that's likely to because it's more advanced disease, but at the same time, much harder to exercise, much higher chance of sort of like we'll talk about a pressure ulcer. You're maybe more time in a wheelchair or in a bed, and then recurrent hospital stays, sort of bouncing back to the hospital as well. So that's why we really need to prevent it from the beginning. So our goals here are to relieve pain, heal wounds, preserve functional limb, maintain ambulation, and then this is very much a complex process. So this is a lot of discussion with me, the patient, family, and the referring doctor about what is the best approach. I have certainly had patients that are non-ambulatory, meaning they don't walk. They use a Hoyer lift to sort of get transferred from one to another. And I discuss with family what is the best step. What's the ultimate goal? And is it worth subjecting you to a major surgery, or should we do something else to try to maintain, minimize cardiovascular events? So these are all things we've discussed: high blood pressure, diabetes, aspirin. So these are the goals of therapy. I'm going to show you some pictures of how we do these things and how we do these in the office. So I told you my job is to get some tests done to figure out where the blockages are. So this is an angiogram, and if you notice, this is the same picture from above where the catheter went in on the right side. You get a little sense of the catheter there, and there's nothing going on the left side. This patient more likely would need a surgery to reconstruct. It's a very long blockage. Stents work well for shorter blockages, more focal areas. This might turn into more of a surgery type. And then all this is the dye, and all this white stuff is cholesterol that has sort of impacted the amount of blood flow going down. So this is the alternative. This is surgery. This is the maximally invasive way. So this is, so what's trying to depict here is the normal blood flow, and this is an occlusion, a blockage in this blood vessel. So your choices are to fix this with a stent or to reconstruct the blood vessel with a bypass. If you ever heard someone who's had a bypass, I don't want to know if you've had it, but a heart bypass. So what they do for a heart bypass, they take the vein from your leg and they connect it to your heart, right? So they connect it to the aorta and then they sew it down to the heart to reroute, basically create a brand new blood vessel. This is the same thing in your leg. We take the vein from your leg and then we sew it to the artery above and below the blockage, so now we've bypassed around it. We can use a vein or we can use a piece of plastic. This is like Gore-Tex. Yeah, please.
You keep mentioning cholesterol.
Yeah.
Is cholesterol causing all this?
Very much so. It's cholesterol dependent.
It is.
Mm-hmm.
So
Yep.
it must be other. There's no other.
Well, so I'd say underlying is calcium with cholesterol, but if you're a smoker, you're more likely to get cholesterol deposition. The reason is that you're injuring the blood vessels, the inner lining of the blood vessels, and then cholesterol deposits there and can become more obstructive in the blood vessel. So all these are decisions or choices of how to fix it, which I would have to make depending upon the patient, the pictures, and what their overall condition are. So the newer trends is that there's been very much a shift away from big surgery. So historically what we did were big surgeries, big incisions. Take the vein from the leg and then reconstruct it here. A couple days in the hospital, 4 hours of surgery perhaps, general anesthesia, risk of heart attack from surgery, risk of infection. So now, newer advances in technology allow for many of these treatments to be done in the office with stents or balloons. So this is how many procedures have been done that are catheter-based and how it's been exponentially rising since the mid-1990s. So this is how we fix it in the office. This is that same cholesterol plaque. As long as a wire can navigate through it, then you can fix it. As long as you can get a wire through it. But there's newer techniques to fix it. There's a bunch of catheters to help you get through, depending upon what the blockage looks like. These are all things that we get trained in as vascular surgeons about how to fix it. These are all microscopic. And then a bunch of different devices to help sort of chew away the plaque. This is a way to get around the plaque, things you don't need to know, but things that I do. These are all ways to fix it. For example, there's a newer technology called a drug-eluting stent or a drug-coated balloon. If you've ever heard that, or if you know anyone who's had a heart stents more recently are drug-eluting, meaning they they attach a chemotherapy drug to the stent. So when the stent gets deployed in your heart, it emits that chemotherapy drug to prevent scar tissue from forming. The concern is once you put a stent in, you're injuring the blood vessel in some capacity. And just like you cut yourself and you make a little scar, the blood vessels can scar in as well and cause a narrowing. So they found that if you put chemotherapy drug on the stent, it reduces the chance that the scar tissue forms. Very much studied in the heart, not so well studied in the legs. There's a couple clinical trials of doing this in the legs, which we're doing now. So these advances come down in the stent, and so they're approved in, for example, in Europe. There's one company that we're using that's approved in Switzerland and in Europe, but is still under investigation in the US. We get to do it as a clinical trial. So we have access to that balloon in our office, but other places do not. So this, for example, is a special device which crosses blockages that are too challenging. So I mentioned that once you get a wire through it, you can fix it. So this blockage is so calcified, so rock hard that a wire wasn't able to go through it. So there's a special device that lets you to go around it. And once you get around it, then you can, again, fix it with a stent. All tools you can have in the office. Yeah.
Can you break that up at all, or does it stay there?
So there's different choices. So you can. Depends on, so the physician will sort of decide. More commonly, most of it will remain, but there are devices that will break it up, whether that's something called atherectomy, which is to break up the clot, to break up the cholesterol.
Which would be better, I would think.
So it depends. So it depends on the, so ordinarily I would agree with you, but it depends a bit on what's downstream. Because if you break it up, where's it going? As long as I'm happy to have a break up and stay in that spot so a stent, or at least soften it up. But we don't have a picture of the anatomy here, but if you only have one blood vessel that goes down to the foot, for example, usually you have 3, but if say 2 of them are blocked, you only have 1, my concern is if I were to break this up, even if a little fragment goes down that one other blood vessel, now I have made a bigger problem. So the surgeon has to sort of decide what it is, but ordinarily, yes, I'd agree with you. There's intricacies to it, which is all sort of you have to determine on the table when doing the procedure. Stents and things you can all do, and then this is an example of what we do in the office. So I'm going to show you this one. There's this more straightforward. Ooh, more pictures. There's a blockage right here. So normally this blood vessel should be going down here. There's a little device that they navigated down, and then once you can get across it, you can fix it. There's a brand new stent going through. I'm going to show you a better example here as well. Right here. Okay. So normally, this is the wire. If you notice, there's a straight wire coming down over here, and there's an obstruction. You notice all this is empty. This is just a big collateral, a side branch coming down, and it's normal right here. But the obstruction is from here to here. This is what will give someone pain with walking. So if we can get a wire through it. That will allow us to balloon it and then ultimately put a stent in. And now the blood flow has gone down normally. You won't see that sort of squirrely collateral blood vessel anymore. That patient would sort of leave the room, sort of we observe for half an hour, and notice that their leg pain has resolved. Now their calf is getting all the blood flow that it needs to be able to walk. Or if they had wounds on their feet, now there's enough blood flow to deliver oxygen and nutrients so that you can heal up the toe wound or whatever. So that's how we handle things minimally invasively. So overall, PAD is highly prevalent. It's oftentimes undiagnosed or misdiagnosed. And diagnostic testing is easy. I'm glad you were able to, it's very easy. It's non-invasive, it's available in the office, in the hospital, on an outpatient basis. You do not need to be brought into the hospital for these tests. And if necessary, there's plenty of treatments that can treat the limb, to save your limb potentially. And we're trying to identify you before these patients present. We need to reduce that 50% number. So what's new in 2024? So since one of the advantages of COVID is that patients have become much more willing to avoid the hospital. So Massachusetts is a bit of a discrepancy here, but very commonly outside of Massachusetts, patients will seek care in an office setting. And now 60% of patients would rather be treated in an office than in a hospital. So vascular care has now shifted very much to an outpatient basis as well. So this started in they're new to Massachusetts in the Northeast, but it started in 2008 when Medicare started allowing for vascular procedures to be done in an office. Before, they had to be done in the hospital. They would not pay you if you did a stent in the office. But now this is beneficial to physicians, patients, payers. And I really think this is the future of care. So the benefit for the patient is that it's very much center of care, it's convenient, it's easy to access. You receive all your testing and education in one visit. So you go in, you get your ultrasound, you see your provider, you'd come back the next week for your procedure, if need be. It's easier to get in than in a hospital setting, faster appointments, and you're sort of in a facility that only does vascular surgery. And you don't have sort of less risk of hospital exposure, hospital-acquired infections, et cetera. And then benefits for the physicians, it's easier for us to be efficient. We can see patients in the office, do a procedure, then go see more patients in the office rather than sort of waiting around. It's better for us, for our lifestyle's better this way. We feel better about our work. Burnout's a big problem with physicians as well, with sort of being handicapped. And we can feel like we can deliver more compassionate care. And then for insurance and payers, it's considerably cheaper to have these procedures done in an office. It's about 30 to 50% less cost to the insurance payers to have these done in an outpatient setting. And so that's what I really believe that this is what the future is going to be, as Medicare sort of being sort of more strapped in. Patients are going to be shifted or highly encouraged to have your procedures on an outpatient basis, as well as we're able to demonstrate fewer complications and save millions of dollars. So thank you very much. This is how you can contact me. So we have an office in Sturbridge. We do have an office in Worcester. That's Ginny, and she apologizes she wasn't able to make it today. But please let me know if you have any questions.